A online meeting video shows a speaker named Sean Couch, CCFFA in the corner. The rest of the screen is taken up by presentation slides. The current slide has 4 pictures representing different stages of parenthood, including pregnancy, newborns, young children, and adolescents. Text on the right reads, Session 1, Prenatal and Postpartum Cannabis Use. What have we learned? July 18, 2024. Session 2, Understanding Safety and Risk Concerns for Infants, Children and Adolescents when Parents Use Cannabis. July 25, 2024.
Awesome. Thank you so much, Han. And I would just say thank you to everyone, the hundreds of people that are on this morning or this afternoon to learn about this specific topic area that is definitely an area of focus and an area that multiple states and jurisdictions have requested information around. And again, that's specifically around cannabis use. And so we want to make sure that you know that this session we have today is session 1 of 2 total sessions around cannabis use. And during today's session, we're going to specifically be talking about prenatal and postpartum cannabis use and really what we've learned. And then I'm super excited for session 2 as well, as that will be a panel discussion with national experts from across the country that are going to help you as attendees understand the safety and risk concerns for infants, children, and adolescents whenever there is parental cannabis use. So definitely make sure that you are here next week for session 2. Now, for our time today, we're going to
The speaker flicks through presentation slides to a slide titled, Agenda. Bullet points read, Setting the Stage. The Shifting Legal Landscape. Potential Effects on Families. Prenatal and Postnatal Cannabis Use. Audience Q&A. Evaluation.
Do a couple of things. I'm going to spend just a couple of moments really setting the stage, really talking about the shifting legal landscape when it comes to cannabis within our country, and then also dive in briefly to some of the potential effects on families in regards to cannabis use. And then I'm really excited. We have a national expert that's going to be on this call as well, Dr. Tori Metz, who's really going to unpack a lot of the research and the findings and her experience when it comes to prenatal and postnatal cannabis use. And then we're also going to end it with a time of Q&A. I also want to make sure to remind everybody, kind of like Han was saying earlier, that you have to be on the entire 60 minutes and able to get those continuing education units. So what we're going to do at the end of the session, we really encourage you to participate in a survey, and there's going to be a QR code at the end of this session that you'll be able to scan. And again, we really encourage you to participate and fill out that evaluation.
A new slide titled, Learning Objectives. The speaker summarizes the text on screen.
Survey. Some of the learning objectives for our time together today is to really ensure that you gain knowledge around the prevalence of cannabis use during both that pregnancy and postpartum period, and then to better understand some of the reported reasons for cannabis use during those phases. And then we also want to make sure that we unpack for you some of the current research around the risks for cannabis use during both pregnancy and postpartum. And then one of the things that I love that the Center for Children and Family Futures does is we want to provide you with strategies that you as professionals across multiple systems can use and implement whenever you are serving families that are affected by parental cannabis use.
A new slide titled, New Cannabis Tip Sheets Available Now. Text reads, a 4-part tip sheets series for child welfare, substance use disorder treatment, court, and healthcare professionals to provide an overview of cannabis use and its effects during the prenatal period, in the home environment, and on adolescent development. Tip Sheet 1. An icon with 2 map pins. Navigating the complexities of cannabis use among parents and adolescents in child welfare services. Tip Sheet 2. An icon with a pregnant person. Cannabis use during pregnancy. What professionals working with pregnant people need to know. Tip Sheet 3. An icon with a family holding hands. Cannabis use. Considerations for professionals working with children, adolescents, parents, and their family members involved in child welfare and the courts. Tip Sheet 4. An icon with 3 people. Cannabis and youth involved in the child welfare system.
One of the last pieces I want to highlight before we dive into some of the content are a set of tip sheets that we have recently made available. And in fact, these came out and we actually found out these are some of the most accessed tip sheets that we've had during the month of June. And they're around cannabis. And again, it's 4 total tip sheets. And what they're designed to do is to provide you as professionals across multiple systems with resources, with practical application strategies that will help you improve outcomes for the families you're serving that are affected by cannabis use. So we definitely encourage you to access those tip sheets, and you will actually see a link that was just posted in the chat where you can access those. So we're super excited that those are available.
A new slide titled, Practice Considerations. Text. Child welfare workers, SUD treatment providers, court professionals. 4 segments titled, Collaborate, Engage, Educate, Review. The speaker summarizes text within each segment.
And with that, one of the things that is within those tip sheets, and again, like I said, something that the Center for Children and Family Futures is very passionate about is not just going over research, but also talking about the practical considerations for you, the practitioners within your various systems. And so some of the things that you're going to see within those tip sheets evolve around these 4 components when it comes to serving families affected by parental cannabis use, and really speaking about how to meaningfully collaborate across systems to serve families better, how to engage those with lived expertise in this field, and how to educate the families that you're serving around content such as safe storage. And then also there are practice considerations for you, the professionals, around how to really review and update your policies to ensure that they reflect guidelines that promote sustainability. So again, all of that content is unpacked in much greater detail within those tip sheets. So we encourage you to access those.
A new slide titled, Is marijuana the same thing as cannabis? An image of a magnifying glass and question marks. The speaker summarizes text following 3 bullet points. Cannabis. Marijuana. Cannabinoids.
To kind of set the lay of the land, one of the questions that we get asked often is, are marijuana and cannabis the same thing? And the quick short answer is no, they're not the same thing. In fact, cannabis, it refers to all the products that derive from the cannabis stevia plant, which contains about 540 chemicals, as where marijuana refers to either the part of products or parts of that come from the plant that specifically contain substantial amounts of THC. And then sometimes another term that you hear often is cannabinoids. And of course, those are the group of substances that are found within the cannabis plant.
A new slide titled, What is cannabis use disorder? The speaker summarizes text and bullet points.
We also want to distinguish and bring to light the definition of cannabis use disorder. So the American Psychiatric Association, they define cannabis use disorder as a problematic pattern of cannabis use leading to clinically significant impairment or distress. And again, that being done as indicated through at least 2 of the established criteria, which you can see listed below, such as a persistent desire to decrease cannabis use with unsuccessful attempts, and also continued use despite social, interpersonal, physical, or psychological problems associated with cannabis use. And again, those are just some of the established criteria.
A new slide titled, Cannabis Use Disorders. The speaker summarizes bullet points.
Now, when it comes to cannabis use disorder, one of the things that we're finding within the research, and specifically a research that was done in 2008, and then another research opportunity that happened in 2021, was that there is data that suggests that 30% of those who use cannabis may develop a cannabis use disorder, and that youth who start using cannabis before the age of 18 are 4 to 7 times more likely to develop a CUD than those who begin as adults. Again, really stressing the importance for early intervention when it comes to cannabis use.
A new slide titled, Cannabis Classification. The speaker summarizes text and bullet points.
Now, one of the things that we are that I want to go through is some potential reevaluation of cannabis's classification as regards to the schedule that it's currently listed as far as Schedule 1 as a controlled substance. Again, currently it is illegal under federal law and it's classified as a Schedule 1 controlled substance, meaning there is no accepted medical use and there is a high potential for abuse. But there have been discussions in Congress and within federal agencies regarding to really wanting to reevaluate cannabis's classification. And in fact, a little over 60 days ago, May 21st, there was a federal notice of proposed rulemaking. And it proposes to change marijuana to a Schedule 3 controlled substance. And just as an example, so you get a sense of kind of what a Schedule 3 controlled substance is, Suboxone and Subutex, those are considered Schedule 3 controlled substances, meaning moderate to low potential for physical or physiological dependence. Now,
A new slide titled, "Which types of cannabis would be affected by the reclassification?" The speaker summarizes text and bullet points.
if this reclassification was to happen, kind of which types of cannabis would be affected. And under federal law right now, cannabis is classified into two categories, marijuana and hemp. And marijuana is their definition for marijuana is the cannabis plant and its derivatives, but it excludes the mature stalks of the cannabis plant, sterilized seeds of the plants, those fibers and oils and other products that are made from the stalks. And it also excludes products that meet that definition of hemp. And hemp, the federal definition for hemp is the cannabis plant or any part of it with a THC concentration of no more than 0.3%. So again, just wanted to provide that clarification there.
A new slide titled, "Proposal to Reclassify Marijuana," based on Department of Health and Human Services evaluation of scientific and medical data. The speaker summarizes bullet points.
So one of the things that the Department of Health and Human Services did is they have done an exhaustive review of scientific data and medical studies around marijuana. And they had an opportunity to review from multiple areas that spoke to either the potential for abuse and dependency, the chemistry of cannabis and how it interacts with the human body, and the history and current patterns of abuse and potential risk to public health. Some of the things that the Department of Health and Human Services found whenever they did this scientific review, some of their findings were that there was a relatively lower level of abuse compared to substances that are found within Schedule 1 and Schedule 2. Thus, again, the proposed discussion that's happening right now of lowering it to a Schedule 3. They also found that it may lead to moderate or low physical dependence, and that there is a low likelihood of psychic or psychological dependence.
A new slide titled, "State-Regulated Cannabis." February 20th, 24. A map of the United States, color-coded in 3 shades of blue. A legend shows darker blue to mean medical-only cannabis program. Medium blue, adult medical and non-medical cannabis program. Light blue, no public cannabis access program.
Now, one of the things that we always encourage is that for every provider that we provide technical assistance to or that we interact with or that we have discussions around cannabis, we always say, know what your state does. And so what you see right here is a map that really talks about how each state is currently regulating cannabis. Some states, they currently only have a medical-only cannabis program. Some have adult medical and non-medical cannabis programs, and some have no public cannabis access program at all. So it's really important that you understand the lay of the land within your specific state.
A new slide titled, "Legal Implications of Reclassifying Marijuana." Medical marijuana. The speaker summarizes text and bullet points.
Now, some of the legal implications if this reclassification of marijuana happens. First, I want to talk about, again, medical marijuana. What are the legal implications if that reclassification happens? First, it would not bring states' medical or recreational marijuana industry into compliance with the federal controlled substances law. And when it comes to medical marijuana, if this reclassification happens, medical marijuana would have an accepted medical use and may be lawfully prescribed. But it's important to note that prescribed substances must be approved by the FDA, and that currently marijuana is not an FDA-approved substance. It's also special to note this legal implication is that manufacturers and distributors of FDA-approved substances are required to register with the DEA, with the Drug Enforcement Agency, and to comply with their regulatory requirements. So prescriptions for medical marijuana would be subject to federal requirements that differ from current state requirements. And one last thing to note, specifically around medical marijuana, is that this would not affect that 2014 medical marijuana appropriations rider, which prohibits federal prosecution of state legal activities involving medical marijuana.
A new slide titled, Legal Implications of Reclassifying Marijuana. Recreational Marijuana and Penalties. The speaker summarizes text and bullet points.
Now, some of the legal implications of reclassifying marijuana as in regards to recreational marijuana and penalties. It's important to note that the manufacture, distribution, and possession of recreational marijuana would continue to remain illegal under federal law and be potentially subject to federal prosecution regardless of state law. Some penalties for violation of the CSA, the Controlled Substances Act, are based on the schedule in which the substance is classified. So again, thinking about that potential reclassification from Schedule 1 to Schedule 3. However, there are parts of the CSA that apply specifically to marijuana. And of course, you can see that listed right there before you. And what this section does, 21 U.S.C. Section 841, is it imposes mandatory minimum prison sentences for persons convicted of violations involving a set of qualities of marijuana or a set of quantities of marijuana and other specific substances. So if this reclassification happens, it does not change that section. And again, the last note around the reclassification is that there is a call for comments to this proposed reclassification that are due on or before July 22nd. So you have a couple of days left, and they can be submitted electronically or via.
A new slide titled, How Cannabis Use Can Affect Families. The speaker summarizes text and bullet points.
Mail. The last piece I want to talk about before we turn it over to Dr. Metz is how cannabis use can affect families. And on a personal level, we find that cannabis use can affect the individual's ability to fulfill their responsibilities, both at work, home, or school. It can increase withdrawal from social situations, as well as exacerbate or cause social or interpersonal problems. Now, when we think about the family, cannabis use can affect families when a family member has or is at risk of developing a cannabis use disorder, which includes individuals who already have a CUD diagnosis, those who are using cannabis in a manner, situation, amount, or a frequency that can cause harm to themselves or those around them. So again, these are just a couple of points that speak to that. But again, I would really encourage you to look at the cannabis tip sheets that unpack this at a greater level.
A new slide titled, What are some of the challenges related to cannabis use in pregnancy and postpartum that you are seeing in your work? Manometer poll, audience engagement activity. 5 bullet points. Social acceptance of cannabis use. Provider perception of harm. Increased access. Differences in state and federal law. Child welfare response to cases involving cannabis.
So what I want to do before I turn it over to Dr. Metz is we want to hear from you, the audience. We want to hear from you on what are some of the challenges that you're experiencing within your jurisdiction when it comes to cannabis use during both the pre-pregnancy or the postpartum phase. Again, what are you seeing within your work? So what you're going to see in the chat is there's going to be a link to a Mentimeter poll within your chat. And what we would like you to do is to click on that link. And whenever you click on that link, it's going to take you to a page where you can provide your feedback, again, on what some of the challenges are that you're experiencing in regards to cannabis use.
A bar graph shows the audience's poll responses to each bullet point. The numbers of responses rise as people respond.
And so we see some, again, child welfare's response. That tends to be a hot topic. The social acceptance of cannabis use. That's one of the things whenever CCFF has done presentations across the nation around this topic, we're really finding that the social acceptance of cannabis use tends to be a large barrier for providers as they're serving families. Again, as we see an overwhelming amount, again, child welfare's response. How does child welfare respond when it comes to a situation where there is parental cannabis use and potentially an infant that is born prenatally exposed to cannabis? Difference in state and federal law. I'm surprised that one isn't higher, because that's always one of the questions that we get whenever we have this conversation is sometimes the differences between the federal and the state level when it comes to cannabis use. So, and of course, we have multiple popping up in the chat as well. So again, as you can see, really the top two concerns that we're seeing across the audience are the social acceptance of cannabis use and child welfare's response. So what I would like to do next is, and I'm super excited to introduce to you, is Dr. Tori Metz. And Dr. Tori Metz, she is a national expert in this field. And so I'm excited to introduce her. She is an OBGYN, as well as an associate professor and a vice chair for research, as well as the maternal fetal medicine division chief with the University of Utah Health. So with that said, I would love to turn it over to Dr. Tori Metz.
Dr. Tori Metz's video appears in the corner. A new slide titled, Cannabis Used During Pregnancy and Breastfeeding. What have we learned?
Great. Thanks so much, Sean, and thanks for all that great information. I'm hoping, as he said, to really try to summarize cannabis use during pregnancy and while breastfeeding, and what have we learned at this point as we've investigated this.
A new slide titled, Disclosures. Then, a new slide titled, Background, with an illustration of a pregnant person. The speaker summarizes text.
I don't have any conflicts of interest related to the content of this presentation. So cannabis is the most common illicit drug used in pregnancy. We know that it does cross the placenta because we see metabolite that has crossed the fetus. And we know there's been increasing use with increasing legalization of recreational cannabis products.
A new slide titled, Prevalence of Cannabis Use. The speaker summarizes text in bullet points.
It's hard to really nail down the prevalence of use. It has ranged in literature anywhere from 3 to 30% during pregnancy. If you really boil it down and look at all the data, I think it's probably somewhere in the order of 7 to 10%. And we don't have the time to go into the details of that, but I can tell you that based on the literature that I keep up with. There are data from the National Survey on Drug Use and Health that is a cross-sectional nationally representative survey that has demonstrated increasing self-reported use over time. 2.4% of pregnant patients in 2002 went up to 3.9% in 2014, 5% in 2016. But we know that self-reported use in pregnancy is significantly underreported because of bias and stigma against reporting. There's been a fair amount of work out of Kaiser Permanente in Northern California. This is a big retrospective cohort that was collected from 2009 to 2017, where they had over 280,000 pregnant people who at their first prenatal visit filled out a questionnaire about substance use and also had a urine toxicology test performed. And they found that 5% of people in that first prenatal visit had a positive UTOX for cannabis, and about 2.5% reported that they used it. And that's what we see in literature. It's about 2 to 3-fold higher when you actually do biologic sampling. They also found that being older, being of a Hispanic ethnicity, and lower household income were all associated with misclassification of not using cannabis by self-report, meaning people who were older, Hispanic, and lower income were more likely to say that they were not using cannabis when they had a positive urine toxicology test.
A new slide titled, Cannabis Use Disorder. The speaker summarizes bullet points.
So Sean talked a little bit about, there is a difference between just cannabis use and cannabis use disorder. We don't have as much data about cannabis use disorder in pregnancy, but this is a study that looked at it using the National Epidemiologic Survey on Alcohol and Related Conditions. They had 414 pregnant and 902 postpartum individuals. And the prevalence of past year cannabis use was 9.8%, and the prevalence of cannabis use disorder was 3%. The odds of use was higher with coexisting mental health disorders, which we certainly see in clinical practice. People note that they use cannabis because they feel that it helps their depression or their anxiety.
A new slide titled, "What are those reasons for use?" The speaker summarizes text and bullet points.
So what are the reasons for use? This is something I get asked a lot. As an OB/GYN, we certainly counsel patients not to use cannabis during pregnancy, and I'll get into some of the reasons why. But people always ask me, well, why do they use it in pregnancy? There's some data on that. This is a Tri-County Health Department survey that was performed in Colorado with clients who are participating in WIC. They have a monthly caseload of about 25,000 clients, and they approached a convenient sample of about 1,700 individuals who answered this survey.
A new slide titled, "Perceived Benefits WIC Survey." A table with 5 reasons for use and their reported use amounts. Help with depression, anxiety, or stress, help with pain, help with nausea or vomiting, for fun or recreation, other reason. Numbers and percentages for use ever, current use, and past use are provided for each reason for use.
And I think what's important and notable here is that people who had current use, which is in this middle column here, they really felt like they were receiving some benefit from cannabis use. Some reported that it helped with their depression, anxiety, stress, their pain. It helped them with nausea and vomiting in pregnancy. It was the minority who said they just used for fun or recreation, whereas those who sort of had use in the past or use ever in their lifetime, it's the majority who used for fun or recreation. So the people who have ongoing use in pregnancy, I think, often perceive that they're getting another health benefit from the cannabis. And that's why it's really important to talk to them about why they're using and be able to give them alternatives.
A new slide titled, "Cannabis Use Disorder." A new table titled, "National Survey on Drug Use and Health Data." Percentages are given for different circumstances in 2005 and 2015. A percentage of 16.5 is highlighted in red.
There is also an increasing perception of safety. And I think that comes up when you guys were doing your survey that said, you are experiencing, issues with this perception of safety. These are also data from the National Survey on Drug Use and Health. And what you can see here in this highlighted portion is that even among those with no past 30-day use of cannabis who are pregnant, in 2005, only 3.5% of them would have said there was no risk of cannabis use in pregnancy, whereas in 2015, that went up to 16.5% who said there was no risk of use. And if you look across the chart there and look in I guess it's the 4th column there, it says past 30-day use, people who are pregnant who had past 30-day use, so current use. In 2005, 26% had said that they didn't think there was any risk. And in 2015, 65% thought there was no risk of cannabis use during pregnancy. And so we're really not doing a good job of counseling and messaging patients about the potential risks.
A new slide titled, "Increasing Perceived Safety." The speaker summarizes bullet points.
So I think that part of the reason that we've struggled to really message this with patients is that there's a lot of uncertainty in the cannabis literature, and there are problems with the existing studies. There's, a lot of times a lack of quantification of the amount of cannabis use or the timing of exposure, which is really important in pregnancy. Birth defects can only occur with exposure in the periconception period in the first trimester. And so if people have use later, then, and that's what we're measuring, that's not going to be a good measure of use. There's difficulty adjusting for a lot of the other confounders that can also affect pregnancy outcomes, including tobacco use, other drug use, and some sociodemographic factors that can also affect pregnancy outcomes. There's also a really high reliance on self-report. And I've already showed you some data that demonstrates that really underestimates the proportion of patients who are using cannabis. This is an old study, but I think it's really notable. This was a study done in 1995, which was a prospective cohort study, meaning they enrolled people and were following them over time. And they were doing structured interviews about drug use, and they were also doing maternal serum toxicology screens. And 70% of the people with a positive THC metabolite or cannabis metabolite on serum toxicology screen denied use in a structured interview. And in serum, it's only around for 2 to 3 days in somebody who uses occasionally. And so, these were, individuals who likely used cannabis within the past few days. And 70% of them said, nope, I haven't. And so I think it's just a reminder that there's a really high social desirability for patients to deny any kind of use in pregnancy, which has, really limited our capacity to study this. These are also different products than contemporary products, though, and I think that's important to remember. A long time ago, the amount of THC in cannabis products was low. That it is very hyper concentrated now in a lot of the products, and we also have a higher proportion of CBD in the products. And so even if these data were perfect, it's hard to extrapolate them to contemporary products.
A new slide titled Perinatal Outcomes Meta-Analysis. The speaker summarizes bullet points. A number of new sets of bullet points will appear under the same slide title, which will also be summarized.
A couple of people have really looked through the literature and tried to summarize everything that's out there and what we know about cannabis use in pregnancy. One of the first times a meta-analysis like this was done was by Gunn and colleagues. They conducted a systematic review and meta-analysis in 2016. And what they said is we were going to look at any kind of maternal, fetal, or neonatal outcomes up to 6 weeks postpartum after cannabis exposure. And we're going to conduct meta-analyses or kind of combine the data when there are 3 or more studies that were available with the same outcome. So they were able to do this for that long list of outcomes there.
The list of outcomes reads: anemia, low birth weight, neonatal length, neonatal intensive care unit admission, gestational age at delivery, head circumference, preterm birth.
And what they found is that there's increased odds of anemia, low birth weight, and neonatal intensive care unit admission for fetuses who are exposed to cannabis. And they said, you know what, there's more studies that are needed. We really still do need to investigate this. Around the same time, also in 2016, Connor and colleagues also performed a systematic review of the literature looking at all these data and did a meta-analysis. Their aim was a little more specific. They said they wanted to estimate if marijuana use increased the risk of adverse neonatal outcomes. And they looked specifically at low birth weight or weighing less than 2,500 grams at birth, or preterm birth being delivered prior to 37 weeks gestation. And they also looked at a list of secondary outcomes, which you will have on the slides, but I'm not going to go through.
The secondary outcomes are birth weight, gestational age at delivery, small for gestational age, level 2 nursery or greater, stillbirth, spontaneous abortion, low OCR, abruption, perinatal death.
And they found 31 studies total that they felt were high quality, should be included in their review. 12 had data about low birth weight and 14 had data about preterm birth. And in their pooled unadjusted data, they saw an association between cannabis and low birth weight and preterm birth. And you can see that the rates of low birth weight were higher in the cannabis exposed than unexposed. Similarly, preterm birth was higher in exposed versus unexposed. But after they adjusted for tobacco use and other confounders, they said that there wasn't any association anymore. So maybe cannabis itself was perhaps not responsible for this. However, they also did a plant sub-analysis where they looked at moderate to heavy use, defined as at least once per week, which isn't a lot, right? Once per week. And they did find that in people who use cannabis at least once a week, that it was associated with low birth weight and it was associated with preterm birth. And these are some of the data that the American College of OB/GYNs relies on in terms of telling patients that, you really would recommend against using cannabis during pregnancy.
A new slide titled Marchand Meta-Analysis. The speaker summarizes bullet points.
There's been a more recent meta-analysis, same thing. They go through all the literature and find the studies that are out there and update it. This is in 2022. They saw an increased risk of low birth weight with 8 studies that pooled relative risk was 2.0. Increased risk of small for gestational age, which means being less than the 10th percentile when you're born at that gestational age and that sex. So there's different curves for male at birth, female at birth. And an increased risk of preterm delivery and an increased risk of neonatal intensive care unit admission. So you're starting to see the theme mostly with small babies that perhaps aren't reaching their growth potential. Some mixed data about preterm birth and some data about increased risk of NICU admission.
A new slide titled Cannabis Use and Adverse Pregnancy Outcomes. The speaker summarizes bullet points. A number of new sets of bullet points will appear under the same slide title, which will also be summarized.
We did an ancillary study of an NICHD cohort, which was called the Monitoring Nulliparous Mothers-to-Be or New Mom-to-Be cohort. These participants were recruited from 2010 to 2013. And basically, it was people who had never had a pregnancy that went beyond 20 weeks before. And we enrolled them and followed them across the course of their pregnancy, collected a bunch of samples, asked them a bunch of survey questions. And then what we were able to do with some NIH funding was to take the urine samples that they'd provided at 3 time points during their pregnancy and assay them for 11-nor-9 carboxydelta THC or THC-COH, the primary metabolite of marijuana. And we're also able to assay them for cotinine, which is how you detect tobacco in the urine or nicotine in the urine, and other drugs. And we had 9,257 total people that we were able to do this with. And overall, we found that 6.6% of them were exposed to cannabis during the pregnancy. I think that's a little tiny bit lower than it is today, in part because this was an older time period when it was less legalized, and in part because these are a unique set of the population that's willing to enroll in a longitudinal research study and be followed in this way during this pregnancy. What we found is that cannabis use was associated with a composite outcome related to placental dysfunction, which included being small for gestational age, hypertensive disorders or high blood pressure during pregnancy, having a stillbirth, and needing a medically indicated preterm birth, meaning that you didn't go into labor on your own, but there was a reason that the physicians or the midwives that were caring for you decided that, yep, you needed to be delivered because you were otherwise at risk. What we found is that this outcome occurred in 26% of the people who were exposed and 17% of those who were not. And that was statistically significant, meaning that using cannabis was associated with these adverse pregnancy outcomes. We did find that this wasn't significant if use was stopped in the first trimester.
A new slide showing 4 bar graphs which are explained by the speaker.
So I think this is important in telling patients, even if you have had cannabis use early in pregnancy, it's still helpful if you're able to stop. This is a figure that we created that really looks at the amounts of cannabis and the risk. This is something that nobody else has really looked at before, and I think comes up a lot. Well, does it matter how much cannabis is used during the pregnancy and over what time period? And this is a really complex figure, but what you're seeing here is on the top is first trimester amounts in the urine. And then the bottom, we looked at time-weighted average amounts of metabolite over the pregnancy. And I think what's important really to glean from this figure is that as on the axis, the amount of exposure increases, on the y-axis, the chances that you have the adverse outcome are higher. And so this is exactly what we would expect with any other kind of drug exposure, right? The more use, the higher the risk. And I think it lends more credence to the data that, that this is an effect that we're seeing. We are seeing what looks like a dose response to cannabis and adverse outcomes.
A new slide titled Anomalies, Systematic Review. The speaker summarizes bullet points.
The other thing I feel like people really want to look at are anomalies. Patients always want to know about birth defects. What are the chances my baby will have a birth defect with these exposures? Somebody did look at this recently. It was published in 2023. They were able to find 11 studies that they felt were high quality to include in this review. And they did find a slightly higher risk of birth defects with cannabis use. And 2 anomalies in particular came up. One was Epstein's anomaly, which is anomaly of the heart valves. And one is gastroschisis, which is where some of the intestines are out on the outside of the abdomen at the time of birth. And, they said, though, that, geez, these studies are really heterogeneous. It's hard to kind of put them together. They're done in a lot of different ways. There's a high risk of bias in terms of how they were done. And there really is inconsistent evidence about this. So we need more data to really be able to counsel patients about whether we think that cannabis use is associated with any kind of birth defects.
A new slide titled Neurodevelopment. The speaker summarizes bullet points.
The other area that I thought was important to cover today is neurodevelopment. I think that people worry about a couple of things when we think about cannabis use in pregnancy. One is the growth, right? Because we think that cannabis probably affects the placenta, and that's why we focused on those outcomes in our study. The endocannabinoid system is really active in placental implantation. So if you have other cannabis coming in, exogenous cannabis disrupting that, then you could see how the placenta may not function optimally. The other thing that people worry about where there's a lot of the natural or endocannabinoid system functioning is in neurodevelopment of the fetus, especially later in pregnancy. The brain is really actively developing. And, people worry that because there is, we know that metabolite crosses the placenta is perhaps their interference with that normal neurodevelopment. There are some data suggesting concern for this. So they're in animal models, which we do because it's helpful because you get rid of all those other confounding factors that we were talking about. They do see alterations in neurotransmitters in rat models, especially in what we call the dopaminergic pathways or areas that process dopamine in the brain. And in post-mortem human fetal brains of individuals who underwent elective termination of pregnancy between 17 and 22 weeks, they also found dopamine receptors were reduced in marijuana-exposed fetuses. It was most prominent in males, and it was directly correlated with the amount of cannabis used during pregnancy, again, speaking to that dose-response effect.
A new slide titled, Prospective Longitudinal Studies. A table with headings reading, Study and Investigator, Initiation Date and Location, Study Size and Population. The contents of the table are summarized by the speaker.
There are a few studies that have really looked longitudinally and followed children over time to see if there's neurodevelopmental effects of cannabis. The main three are called the Ottawa Prenatal Perspective Study, or OPPS, the Ottawa study. There's a Pittsburgh study called MHPCD, and there's a Generation R study out of the Netherlands. And all of these studies follow slightly different populations, which you can just see described there. But they've followed them over time to see if there's any neurodevelopmental problems with the children.
A new slide titled, Neurodevelopment. The speaker summarizes bullet points. A number of new sets of bullet points will appear under the same slide title, which will also be summarized.
Importantly, these data are really limited by confounding factors, right? It's really hard when you're looking at children at 4, 6, 10, 14 years of age, as I'm going to describe here, to say that any changes we see in neurodevelopment were related to in utero exposure, right? Versus all the differences then in the home environment, their upbringing, different exposures themselves during their lifetime before we're assessing these. So I think that's important to remember. They did find in the OPPS study that there were no differences between groups below the age of 4 in neurodevelopmental measures. At age 4, they did start seeing increased behavioral problems, worse language comprehension, decreased sustained attention and memory. And in the Pittsburgh study, they saw decreased verbal reasoning at age 6, worse academic performance at age 10, and increased substance use at age 14, even after adjusting for ongoing parental substance use. In the Generation R study, which is a population-based prospective cohort from fetal life until young adulthood, they saw higher aggression scores in cannabis-exposed girls, but not boys at 18 months. They saw no differences in behavior at 3 years of age, and they had ongoing follow-up into adulthood for children born between 2002 and 2006. So I expect we'll continue to see information from this group. There's a couple of other publications that are worth mentioning in terms of neurodevelopment. This is the ABCD study, which some of you may be familiar with. It's the Adolescent Brain and Cognitive Development Study. They're really following this. It's a cross-sectional study of almost 12,000 children that they're following over time. In this cohort, 6% of them had been exposed to cannabis prenatally, and the mean age at which they checked in on these kiddos was almost 10 years of age. And cannabis exposure after maternal knowledge of pregnancy, so some exposure during pregnancy, was associated with greater psychotic-like experiences and externalizing attention, thought, and social problems in the offspring. We did a secondary analysis of 2 maternal fetal medicine units network studies, which were initially randomized controlled trials that were looking at maternal thyroid function, but we kind of took that data where they looked at all these cognitive outcomes in the children related to thyroid function, and we wanted to see how the cognitive outcomes were related to cannabis exposure. So we were able to include 1,197 pregnant individuals. 8% of them were positive for cotinine or nicotine use, and 4% were positive for THC. Interestingly, any kind of drug use was supposed to be exclusion for this study, but we know that some people aren't going to report it. And we saw no difference in childhood IQ at 60 months of age or 5 years of age between those who were exposed and unexposed. But we did see worse attention scores at 48 months of age in those who were exposed. So starting to see, attention starting to come up in a variety of these studies.
A new slide titled, National Academy of Sciences. The speaker summarizes bullet points.
The National Academy of Sciences and Medicine is obviously a very respected organization that has gone through and did a really thorough review of this in 2017. If people are interested in this, they have a whole chapter on a pregnancy, cannabis and pregnancy, but the general topic is health effects of cannabis. And what they ended up concluding is that there's a consistent association between prenatal cannabis use and lower birth weight. There's a limited evidence of an association between cannabis use and neonatal intensive care unit admission. This was really just starting to develop at that time. And there's insufficient evidence of an association between cannabis use and neurocognitive outcomes. And the reason they said this is exactly what I brought up. You can't adjust for these other subtle environmental differences and confounding that's occurred since the time of birth.
A new slide titled, Breastfeeding. The speaker summarizes bullet points. A number of new sets of bullet points will appear under the same slide title, which will also be summarized.
So really briefly in terms of breastfeeding, there's not that much data on breastfeeding, so it's easy to cover this pretty quickly. We do know that THC metabolite passes to the neonate in breast milk. There was a letter to the editor in the New England Journal of Medicine in 1982 that included data from 2 patients. And when you hear people say that the levels in breast milk are 8 times the plasma, that's actually from 1 patient in this letter to the editor. So I just like to remind people that sometimes we perpetuate these ideas and these data when, we probably shouldn't, right? This was literally 1 patient that had used chronic heavy use, and they did have a level in the breast milk that was 8 times the plasma. But that's literally 1 patient. So we just need more data to be able to counsel patients. We have a little bit more data. This is an observational study of eight women who purchased a product with known concentration of THC in Colorado. They abstained from use for 24 hours prior, at least that's what they reported. They had inhaled cannabis. They then inhaled the cannabis product that they were told to purchase. They collected their breast milk at 20 minutes, 1, 2, and 4 hours later. And they found the exclusively breastfed infant ingests a mean of 2.5% of maternal dose. So some ingestion is likely occurring, but it's probably at pretty low rates. I think, there's problems with this study, right? They tell patients go get high and then really very carefully try to, do this research study. But this is helpful. These are more data about breastfeeding and cannabis use. There's 54 samples. This is another study with 54 samples from milk donors, so milk bank. They found that THC was metabolite in 63% of the samples who reported use up to 6 days after their last reported use. And the median concentration was 9 nanograms per ml, so low concentration but present. And not surprisingly, the number of daily uses and the time that has elapsed from sample collection to analysis were predictors of THC concentration in the breast milk. So the more people have use, the more we see in the breast milk. This is a prospective cohort study that I was part of when I was working in Colorado. And what we really wanted to do when we undertook this study was to estimate the time to elimination of marijuana metabolite from the breast milk. Our goal was to enroll 25 participants. One of the inclusion criteria was a plan for abstinence. So we were trying to only enroll patients that said, 100%, I'm going to stop using today. Well, it turned out that only 12 of the 25 actually remained abstinent when we did plasma sampling across the duration of the study period. So it's harder to stop sometimes, I think, than people think. And these patients primarily did inhalational consumption during pregnancy, most of them more than twice weekly. And we found detectable THC in the breast milk in all participants across the entire 6-week study period. So even among the 13 that abstained, we still had metabolite 6 weeks out.
A new slide titled, American College of Obstetricians and Gynecologists Committee Opinion. The speaker summarizes bullet points.
So what should we tell people? The American College of Obstetricians and Gynecologists say that people should not use marijuana during pregnancy or while lactating, and that OB/GYN should not prescribe for medicinal purposes to pregnant or lactating individuals, and that we have insufficient evidence for effects on the nursing infant. We have no data currently about how much the neonatal gut absorbs the cannabis metabolite and how much of it gets into the bloodstream and if that has any effects in the neonate. So there's a big gap there.
A new slide titled, How Are We Doing Now? The speaker summarizes bullet points. A quote will appear under the same slide title, which will also be summarized.
I think that leads to us not doing a great job of counseling patients. So in 2016, these investigators recorded patient encounters and evaluated the obstetric provider response to disclosure of cannabis use. This was a high-risk population, high-use population. 19% of the people who were having an OB intake or a new OB visit reported use. They had interactions with 47 different healthcare providers, and 48% of the time, the provider did not even respond to the cannabis disclosure, meaning the patient said, yep, I use cannabis, and they said, okay, do you use tobacco? So they just went on to the next thing without even talking to them about it. And when they did discuss it, the response was really nonspecific and focused on punitive measures, toxicology screens, child welfare services, rather than trying to work with the patient about, okay, why are you using cannabis and what can we talk about in terms of alternatives? This is a quote from one of the docs that are, or one of the providers, could be a doctor, could be a midwife, that interact with the patient, said, you know how it alters your mind when you have it, how it makes you feel? So think about what that's doing to the baby that's not even quite formed yet. It gets the effects as well. And we don't want to do that to the baby. This is not very helpful, right? It's very nonspecific. We really need to educate patients to empower them to make informed decisions.
A new slide titled, Dispensary Project. The speaker summarizes bullet points.
We did a study when I was in Colorado that actually got a lot of media attention at the time. This was in 2018, where we called dispensaries. So 400 randomly selected dispensaries in Colorado. The mystery caller said they were 8 weeks pregnant with nausea. And nearly 70% of the dispensary employees that answered the phone said they had a cannabis product recommendation for this person. Predominantly, they recommended edibles. 65% of them said it was based on their personal opinion. So they'd say, well, personally, or in my experience, or, my friend. Only 32% recommended a discussion with a healthcare provider without prompting. So patients are being told to use cannabis during pregnancy, and we have an opportunity to educate them. Otherwise, they're going to get information from other sources. This was a big deal when this came out because cannabis dispensaries are not supposed to provide medical advice, and they were not supposed to advise cannabis during pregnancy. So there's a lot of education that happened in response to this in Colorado at the time.
A new slide titled, How Are We Doing Now? The speaker summarizes bullet points.
So how are we doing now? They're not great still. So this actually just came out in 2023. This is a cross-sectional study using PRAMS data. And they looked at prenatal care visits in 8 states. 2 of them had legal cannabis, and this was about 11,000 participants. 37% said they were not asked about cannabis use during their pregnancy at all. 63% said they were not advised against cannabis use. And of those reporting cannabis use, 50% of them said, yeah, they were actually advised. So only half, a little less than half. And surprisingly, 7.7% said they were advised to use cannabis at prenatal visits. So we're missing the mark here.
A new slide titled, What Do We Tell Patients, Clients, Parents? The speaker summarizes bullet points.
So what do we tell patients, clients, parents? I think, we really need to tell them there's no known benefits of cannabis use during pregnancy. There's not been any studies that have shown that it's beneficial for any of the things that they note that they use it for. And there are studies that demonstrate benefit of some other medications that we can use. There are possible risks of cannabis use in pregnancy. And the main ones I talk to patients about are the risk of poor fetal growth, which makes us worry about how it's affecting the placenta, possible increased risk of NICU admission, which I think has come up more and more often. And then these concerns about neurodevelopment, which I, tell them are a little bit less certain in terms because there's just differences in environment and things that are hard to adjust for. But usually when I talk to patients about it, they say, oh, I didn't know there was a concern, I can stop. I think we need to advise patients not to use cannabis during pregnancy, and that there's no known safe amount of cannabis in pregnancy and while breastfeeding. But anytime they can stop, it's going to be beneficial compared to ongoing use.
A new slide titled, When Do We Have These Conversations? The speaker summarizes bullet points.
So when do we have and how do we have these conversations? we really are advised by American College and others that of OBGYNs and others that verbal screening should be incorporated with standard scripts during contacts with parents, patients, clients. So in OB, we do this at prenatal appointments. You could do it at an initial intake appointment, at child welfare family assessments, but it's just a universal verbal screen for any kind of substance use. And we need to just empathetically and explain the potential risk without judgment. Otherwise, patients, clients, parents are just going to shut down.
A new slide titled, Screening for Cannabis Use. The speaker summarizes bullet points in a small table titled, An Idea Quick Screen Question.
It's best if we just screen everyone with a standard tool. So really, that's really important in medicine and OBGYN. We don't want to do, quote, risk-based screening. We don't really know who's at risk. We just need to screen everybody in the same way, in a non-stigmatized, non-biased manner. One way to do this is with the NIDA Quick Screen, which asks questions about pregnancy, past partner, and parental use, and just basically goes through and says, in the past year, how often use the following, and it screens them for all these things. We do this at our first prenatal visit, and if people screen positive, then we talk to them about the results.
A new slide titled, Universal Verbal Screening. The speaker summarizes bullet points.
We need to respond to high-risk screening by advising, assisting, arranging referral, and offering ongoing support. Risk-based screening, like I mentioned, in terms of looking for things like lack of prenatal care, previous child welfare, other stigmatizing things, can result in further bias and stigma, can turn patients away from interacting with us in the future, and really results in missed opportunities to engage individuals into services and treatment who may be interested.
A new slide titled, How to Have These Conversations. The speaker summarizes bullet points.
We want to use these standardized screening tools in everyone. It eases service providers' potential discomfort because we're just do this in everybody. And I say that to my patients, we screen everybody for this. We need to ensure access to a clinical assessment for parents to determine presence of substance use disorder, engagement, and treatment, and for infants and children to determine need for developmental services.
A new slide titled, Motivational Interviewing. The speaker summarizes bullet points.
And what is motivational interviewing? This is really a clinical method for guiding patients to make change in the interest of their health by eliciting their own motivation for change. So talking to patients about, oh, I see that you're using cannabis. Can we talk about the risk of cannabis use? Why, what's your motivation to stop using cannabis use? Can we get there? It shouldn't be judgmental. It shouldn't be provider driven. It shouldn't be shaming. It shouldn't be persuasion. It's really open conversation about where they are and how you can facilitate them.
A new slide titled, Referral to Treatment. The speaker summarizes bullet points.
In terms of referral to treatment, there are local specialized clinics for substance use disorder and pregnancy. We're very lucky at University of Utah Health. We have a very advanced multidisciplinary clinic related to substance use disorder and pregnancy. I recognize that's not available everywhere, but often we can refer people, people can be referred into us. There's different models. There's hub and spoke models. There's collaborative models. There's integrated care models. And I do think this is becoming more and more known, more and more recognized entity of substance use in pregnancy. And we're seeing more and more engagement in the medical community in terms of providing services for these patients.
A new slide titled, Where do we go from here? The speaker summarizes bullet points.
So where do we go from here? I think that there's more research needed. And of course, I say that as a researcher, but I think that also as a clinician who's engaged in caring for these patients and families. I think that biologic sampling from a research perspective is critical because we otherwise are misclassifying people as not using cannabis and then we're looking at their outcomes. From a clinical perspective, right, we're just going to ask them. We don't need to be doing toxicology testing. But when we're talking about research and we have appropriate protections in place so it's not harmful to patients, biologic sampling really helps us answer the question more rigorously. We really need to look at timing and quantification of exposure. If we're looking at birth defects, did the exposure occur at a time where it could actually result in a birth defect during that time period in early pregnancy and embryogenesis? There are additional areas of investigation, congenital malformations, maternal morbidity, and neonatal morbidity and NICU admission that I think we need more information about.
A new slide titled, Grant Support. Bullet points read, University of Colorado CCTS Child Maternal Health Junior Pilot Program, Women's Reproductive Health Research Scholar K12 HD 001271, NIDA, R01DA 049832.
I've had a lot of grant support for the research that I presented to you all today, and so I'd just like to recognize that here.
A slide titled, "Thank You," with an illustration of a pregnant person holding their baby bump. An email address, torri.metz@hsc.utah.edu.
And I want to thank you all for attending. And there's my email if people have other questions. And I think we wrapped up in time for a few questions. Thanks so much.
A new slide titled Audience Discussion. A new speaker's video appears, named Handow. Speakers' videos reappear when their voices are heard.
A sprint towards the finish line. And then for those in our audience, again, we will send out this presentation. So you will have all of the great material that both Sean and Dr. Metz covered. I know in the registration questions, many of you had questions about what does the current research say about use of cannabis during pregnancy and during breastfeeding. So the information that Dr. Metz shared, hopefully it will be highly informative to you. So now we have a little bit of time left for our audience discussion. We received many great questions during both the registration process as well as throughout the presentations. Unfortunately, we don't have enough time to cover all of your questions, so we will respond to each individual question that we do not get to during this discussion portion via email. But we do have, the good news is we do have some time for a few questions. So the first question, perhaps Dr. Metz, is there a difference in the potential effects of cannabis use during pregnancy or while breastfeeding, specifically based on how the product is consumed or the type of product? For instance, are there differences on the potential effects based on the type of product, such as in plant form, oil, lotion, or an edible product?
It's a great question. And I will tell you that there are essentially no data on different modalities of use at this time. Even when we look at it now, though, with all the modern products and we think, oh, everybody must be using edibles, we find that actually most people are still inhaling cannabis products. And so most of the information that I provided would be related to inhalational use. I think it's important to remember, though, that no matter how you consume it, ultimately the metabolites are ending up in your bloodstream. That's how you clear it. And when things end up in your bloodstream, that's how they cross the placenta. So I think that regardless of sort of mode of use, we are going to get that same kind of exposure metabolite that then crosses the placenta that probably results in the same adverse outcomes. But I think that we do need to delve more with legalization into use of edibles and whether we see any differences, especially with like CBD products compared to predominantly THC products. And there just aren't any data about that yet.
Thanks, Dr. Metz, for that insight. We actually may have time for maybe a couple of additional questions than I had originally thought. So Sean, let's see. If the results of a drug test administered to an infant at birth indicate cannabis, are Child Protective Services contacted, and is the parent required to enroll in a substance use treatment program?
Yeah, great question. And I would answer that by saying every jurisdiction is unique. Every state is unique in their reporting requirements. But I will say in our work that we're doing with multiple states, we see a shift as far as CPS reporting policy and procedures to being less focused on the substance and more focused on how does that impact the ability to parent, the ability to provide a safe, stable home, those pieces right there. So that's where we're seeing the landscape shift across the nation, is to not necessarily say, okay, there's a pause talks for this specific substance. That means we do X, Y, and Z. Instead of like, no, let's look and let's figure out how is that impacting the ability to parent and the ability to provide a safe, secure environment for the infant.
Thanks, Sean. Again, I think you may have answered a part of this in your response to the first question. How does cannabis use affect parenting, and does it lead to unsafe conditions for the children?
Yeah, great question. Again, how does cannabis use affect parenting? It could, I would say it's possible that it could affect in multiple different ways. One of the ways that I like to highlight is when we talk about like safe storage, and especially with edibles becoming more and more popular, we tend to find accidental ingestion to be one of those critical areas when it comes to the safety of infants. So that's one area that we find. But again, I would also encourage everybody to check out those tip sheets, because within the tip sheets, it goes into even greater detail that we can go in here for time's sake on some of those factors.
Thanks, Sean. Thank you, Dr. Metz.